Good evening. It's so good to be back amongst friends at this WCI conference, even though virtually. And I thank Dr. Neeta Nair for this kind invitation. This has been an interesting collation of data from 7 collaborating centers that Dr. Neeta initiated. And she has asked me to discuss the data that we have collected regarding approach to the axilla. Well, management of axilla is an essential component of breast surgery or breast cancer management for various reasons. And the clinical assessment, including imaging, gives us the clinical nodal staging, and then pathological assessment in form of central lymph node biopsies or axillary dissection gives us the pathological nodal staging. The management of axilla is entirely dictated by the clinical nodal stage of the disease. Uh, Patients who have CN0 disease, they undergo central lymph node biopsies, and those who have metastatic nodes upfront or following neoadjuvant chemotherapy, they undergo axillary dissection. There are patients who have metastatic nodes and where we would like to do axillary lymph nodal dissection. And the standard way to manage axilla is to do a level 1 and 2 dissection. There is some bit of discussion ongoing regarding how best to manage the level 3, whether there should be a routine dissection of level 3 or should it be selective only for patients who have enlarged nodes in third level 3 or bulky level 1 and 2 nodes. So in terms of the data that we have collected from the 7 collaborating centers, this overview would have been discussed by the previous speakers, but I would like to point out that there is considerable homogeneity in the data. At the same time, there are a number of common points which we would like to highlight. So these are the patient characteristics. Some 56% of the 7,674 patients data that we collected actually had operable cancers, and rest 44% had locally advanced. 70% of the patients had hormone receptor positive, and 17% had triple negative cancers. In terms of clinical staging of the axilla, only 3 centers reported routine use of axillary ultrasound, and almost none underwent ultrasound guided core biopsies and clipping. Of those patients who had operable breast cancers at presentation, CN0 stage was seen in about 58% patients, and the rest 42% had metastatic nodes or palpable nodes at presentation. And in these patients who underwent upfront surgery, 55% had pathological node negative status, and rest 45% had pathologically node positive status. Of patients who had locally advanced cancers at presentation, 15% had CN0, and the rest, 85%, had CN1 or worse disease at presentation in the axilla. Sentinel lymph node biopsy as a surgical staging procedure was utilized by all the 7 participating centers. We collected data on 1,717 patients. There was a wide range of techniques and dyes used. Dual dye was used in 25% cases, blue dye alone in 53% cases, radiocolloid alone in 5%, and ICG in 17% of cases. All the centers, irrespective of the dye used or technique used, reported a very good 94% to 99% sentinel lymph node identification rate. The median number of nodes retrieved ranged between 1.8 to 5, and as a result of sentinel lymph node biopsies, 56% of patients could be spared of axillary lymph nodal dissection. Only about 25% of patients who had pathological N1 disease and only 1 or 2 metastatic nodes were spared of axillary dissection, but vast majority underwent axillary dissection if there were even a single metastatic sentinel nodes. Low axillary sampling as a pragmatic low cost alternative to sentinel lymph node biopsy was reported by 2 centers. In the 946 patients these centers reported, the lymph nodal identification rates were 77% and 100%. The median number of nodes retrieved were 3 and 8 in these 2 centers. As a result of this, 64% of patients could be spared of axillary lymph node dissection when they did not have any metastatic node in the sample nodes, and PN1 patients almost universally underwent axillary lymph nodal dissection. In patients who had upfront axillary lymph node dissection, such patients who presented with CN0 disease, and this reflected roughly 1/4 of all patients with CN0 disease presenting upfront. These were perhaps patients who could have undergone sentinel lymph node biopsies, but perhaps due to lack of facilities or some logistic reasons, had to undergo axillary lymph node dissection. uh, 50% of these patients had PN0 and PN1 or worse status found in the axillary lymph node dissection specimen. The level 3 dissection was reported to have been performed between 32% and 100% of these patients. Such patients who had upfront axillary dissection and who presented with N1 to N3 disease upfront, the median number of nodes retrieved ranged between 10 and 26. Level 3 dissection was reported to have been performed in 19% to 100% of patients. One quarter of all these patients, or one third of the patients, actually had PN0 disease, and rest 85% had, rest 66% had pathologically metastatic nodes detected. Now let's discuss patients who had axillary surgery following neoadjuvant systemic treatment. A very small proportion actually underwent sentinel nodes or low axillary sampling. Almost all patients underwent a standard axillary dissection following neoadjuvant systemic treatment. And in these patients, again, the number of nodes retrieved range between 7 and 16. And the level 3 dissection was reported between 58% to 100% when these patients had CN0 disease at presentation. In patients who underwent post-NSCT axillary dissection and who had CN1 or worse staging at presentation, level 3 dissection was reported between 81% and 100% of patients, and the median number of nodes retrieved range between 6 and 26. So, in summary, in this interesting multicenter data of breast cancer, more than 50% of operable breast cancer patients present with CN0, thus allowing us to utilize sentinel lymph node biopsies in vast majority of such patients. All collaborating centers utilized sentinel lymph node biopsy, though there is still some scope of improving the proportion of patients who can be spared a routine axillary dissection. In this direction, it is perhaps worthwhile evolving innovative, convenient, non-nuclear medicine technologies which are low cost and which will make sentinel lymph node biopsies more acceptable across Indian centers. There is considerable variation in the techniques and dyes used, but irrespective of those, there's a high, more than 95% sentinel lymph node identification rates. Utilization of intraoperative frozen section histology has been reported by all the centers, and this facilitates one step management of axilla. A significant proportion of patients who have PN0 sentinel lymph node status documented can be spared of axillary dissection, but very few are actually spared even when they have metastatic sentinel lymph nodes. In this regard, I think it is worthwhile mentioning this kind of innovative study where we compared low cost radiopharmaceutical versus the commercial radiopharmaceutical and reported that the low cost in house prepared radiopharmaceutical was equally accurate. This is perhaps the kind of innovation which will help utilization of sentinel lymph node in more and more Indian centers. Further, there are few patients with locally advanced cancers who present with CN0, and many have YCN0 stage. However, in such cases, there is a relatively lower utilization rate of sentinel lymph node biopsies. The available data does not support sentinel lymph node biopsies being accurate in patients with real locally advanced breast cancers, and axillary lymph nodal dissection perhaps remains the standard of care in these kind of patients. Our studies, couple of them, such as this, presented at the SABCS and then published later on the World Journal of Surgery, where we reported that patients who had large operable cancers, irrespective whether they are underwent upfront or post NSCT sentinel lymph node biopsies, they had fairly accurate sentinel lymph node biopsy performed. However, patients who had T4B or N2 or worse stage at presentation, they had dismal sentinel lymph node identification rates upfront or post NSCT and very high false negative rates. So, in the end, this interesting multicenter data, it suggests that sentinel lymph node identification utilization is good. However, in patients who have undergone neoadjuvant systemic treatment in Indian patients, especially the operable cancers, we need more data to be collected. Targeted axillary dissection performed in patients uh, who have undergone neoadjuvant systemic treatment is another area where we are lacking at this moment. And we also need to document over coming years the outcomes of the auxiliary management, both in terms of their oncological outcomes, the local regional recurrence rates, the survival rates, and the lymphedema and morbidity data. So, in the end, I thank Dr. Neeta Nair again, and thank you all for a patient hearing.